Hi, everyone. Thank you for joining us. We'll just leave a minute to give time for some more participants to join. Okay, it looks like the number of participants is about stable now, so we'll get started. So once again, hi everyone. Thank you so much for joining us today. My name is Haley. My pronouns are she and her. I'm a project officer with CPHA's Substance Use Project, and I'll be co-moderating the webinar along with my colleague, Karen. So while we are working remotely, I would like to acknowledge that CPHA's office is located on the original unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with First Nations, Inuit, and Métis peoples in their governments and realizing meaningful truth and reconciliation. And I'll move on to the next slide now about our Zoom details. So just for a bit of housekeeping, all participants are muted, but we hope to engage you today throughout the webinar and using other features. If you have general comments, please post them in the chat box in the toolbar at the bottom of your screen, which is visible to all participants. And if you have any questions for the presenters, please post them in the Q&A box. The format for this webinar will involve a presentation followed by a question and answer session at the end of the webinar. If you think of any questions during the presentation, please drop them in the Q&A box and we will try to get to them all in the last several minutes if possible. And this webinar is being recorded and the recording will be made available on CPHA's YouTube channel. Okay, and I will move on to the next slide and introduce the presentation. Okay, so once again, thank you for joining us today for this webinar entitled Having a Voice in Saving Lives, a qualitative survey on employment impacts of people with lived experience of drug use working in harm reduction, which is being hosted by the Canadian Public Health Association. The involvement of people who use drugs working in harm reduction has been a significant and expanding component of overdose prevention interventions across the nation. While such initiatives have proven effective in decreasing drug-related harms among people who use drugs, there exist unintended negative impacts. In 2018, at the National 2018 Stimulus Conference held in Edmonton, Alberta, 50 qualitative surveys were completed by people with lived expertise of drug use working in harm reduction from across Canada. The surveys focused on the benefits and negatives of peer employment and recommendations for organizational transformation. The CRISM People with Lived Expertise of Drug Use Working Group will be presenting on the survey's findings while discussing their own experiences working on harm reduction. And now I will turn it over to our presenters to introduce themselves and for the rest of the presentation.
Who is the first presenter?
Sorry, I was stuck on mute. Frank, do you want to begin with your introducing yourself? And then we'll go to the presentation.
Oh, thank you. Hi, my name is Frank Crichlow. I'm the president of the Canadian Association of People Who Use Drugs. I'm a harm reduction worker in a health at South Riverdale Community Health Center. I've worked in the overdose sanctioned and unsanctioned sites for over 3 years. I currently do, I represented Canada at the United Nations in 2020 and 2019 as a Canadian delegate. I presented on race, poverty, and harm reduction, and I do a lot of public speaking for my community.
Thank you, Frank. Next, we have Michael Nurse.
Good afternoon. My name is Michael Nurse, and I am a harm reduction service practitioner working in Toronto. And I do that work through the Black Coalition for AIDS Prevention. I'm also a member of the Canadian Association of People Who Use Drugs and a member of the Toronto Drug Users Union.
Thank you, Michael. Next we have Sean LeBlanc.
Hello, everybody. My name is Sean. As Jade said, I'm in Ottawa on the unceded land of several Indigenous people, including the Outaouais, the Ottawa, the Algonquin, and the Huron. I am the founder of the Drug Users Advocacy League. I did that in 2010. I'm a very proud board member of the Canadian Association of People Who Use Drugs. Up until recently, I did outreach work with Ottawa Inner City Health, and but I hung up my outreach boots for research shoes. So I'm now working with Mount Sinai and St. Michael's in a research capacity. And I'm really happy to be here today.
Thanks, Sean. Unfortunately, Alexandra could not make it today. So we have Tamar Austin.
Hi, everyone. I'm Tamar Austin. I'm currently in Vancouver, the unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh. I'm a research coordinator at the BC Centre on Substance Use. My work focuses on exploring the experience of women who use drugs, labor, and care. And I'm also passionate about addressing issues concerning racism, gender-based discrimination, and the resulting inequities.
Thanks. And I'm Jade Boyd. I'm a research scientist at the BC Centre on Substance Use in Vancouver, BC, and an assistant professor in the Department of Medicine at the University of British Columbia. And thank you for inviting us for this talk. And for those of you who are joining us today, we're going to rotate our speaking as we go, so please bear with us through our transitions. Before I go into detail, I just want to note that we do use the term peer in this presentation as it was used in the survey. We had a lot of discussions about this term in our group, and it can refer to a lot of things, including people with lived experience of illicit substance use whose employment may or may not be defined by that practice. But we also want to acknowledge its inherent contradictions because it also demarcates an invisible boundary that results in inequalities between those whose work roles are defined by their substance use practice and those who are not. Just gonna change our slide there. And I also want to mention that all of the images are by people in our group. This is an image of our manuscript for the study that we're talking about today that was published in Harm Reduction Journal. And I just want to draw your attention to the acknowledgements because we have over 15 people in our group. We couldn't list them all in the authors section, but all of these people are the authors, and those of us presenting today are only a few of the people that participated in the work of this manuscript and study. So I'm just going to give you a little bit of background. It was already mentioned by Haley, but this project began through our national working group, which has representatives from Ontario, Toronto, the Atlantic areas, Nova Scotia, British Columbia, and the Prairies. And we were coming together every 3 weeks to once a month to discuss important issues related to the overdose crisis. And one of the issues that began to come up a lot was the way that people with lived experience of substance use were working in frontline areas of harm reduction in doing high stakes work with overdose reversals, but were experiencing things like they were extending themselves beyond the actual job. So they were experiencing things like emotional labor that wasn't always accounted for, and also experiencing few services for support, lack of sick leave, lack of advocacy, even though they were doing critical work. So we wanted to think of something we could put together quickly. And an idea came up that we do an open-ended survey at the stimulus conference that was happening in Edmonton, because we knew we were going to get a lot of people attending that conference who might be interested in hearing what they had to say. And surveys aren't an ideal method, but they can be distributed quickly and were useful because they didn't overburden the working group that was coming up with these issues. So we just had some very simple open-ended questions. What are your experiences working as a so-called peer in harm reduction? What are some of the benefits and the negatives? And what are some of your recommendations for change? And we're just going to go over some of the findings from the survey that are present in the manuscript. And then some of us are going to give you some firsthand information about their experiences on these topics. Before we began with the research, we acknowledged that there was a lot already saying that the involvement of people with lived experience of drug use in healthcare and addressing substance use was critical, was proven to be extremely effective, especially in reaching those who were having difficulties accessing traditional public health initiatives. And we also knew that there was a lot of data talking about the legal and social discrimination and marginalization and stigma that people with lived experience were experiencing without employee and social supports at the time. So this kind of formed the premise of our idea to look into these issues and just get a little bit of a sense of what people from across Canada were feeling about it with just 50 surveys filled out by participants.
Hi, everyone. So I'm just going to go over the main findings of the surveys. So we noticed as we analyzed them, there were several reoccurring themes. The first set can be categorized as benefits of peer work. The themes we found weren't distinct, but tended to intersect with one another. Peers explained that they felt empowered and confident from helping others within the drug using community. They also felt that their experience as people with lived expertise of drug use was valued within their workplace. This is significant given the amount of stigma experienced by people with lived experience of drug use. And participants also felt that their positions provide them with an opportunity for knowledge and skill building. And this is demonstrated in the following quote: "The benefits I experience are disseminated. Information about my HIV, HCV, drug use, harm reduction. Knowing that through my work that I saved a life. Just in general, it's beneficial for people who have stigma to teach, to not feel like scum, a low life." Much like the themes related to the benefits of peer work, the themes that arose around the negatives of peer work were also intersected. So participants described experiences with tokenism, where they felt they were hired solely for their peerness and did not feel their voice was valued, as seen here with the quote, "When do I stop being a peer?" Additionally, participants disclosed experiences of stigma and discrimination in relation not only to their drug use, but also intersecting with stigma in relation to other axes of oppression, such as racism, colonialism, and patriarchy. Finally, there were complaints around unrecognized work and wage inequity, as demonstrated by the following quote: "I need to educate my colleagues all the time. I'm the only peer at my site of work. I do more emotional work than my colleagues, but I'm paid the same. This invisible workload isn't recognized. My job doesn't end when I leave my job, but I'm not paid more. At the beginning, I felt lower in the hierarchy at my job. Now it's better, but I'm not in the group like everyone else." In addition to the benefits and negatives of peer employment, study participants shared their recommendations for institutional change within harm reduction services and community organizations, expressed here: run on a model that lets everyone get a chance to facilitate, schedule, run the show, so it can empower peers who use drugs and show they are of value to the team as they are more than a connection to the streets. And here, we need to make this system set up more available for peer support and Aboriginal individuals to be able to be managers and our team leads, and to be treated with respect and valued for their lived experience, and to be viewed as just as important. So in conclusion, certain factors can have serious consequences for people with lived expertise of drug use who work in harm reduction. This can include continued exposure to stigma for drug use and other intersecting axes of oppression, workplace discrimination, power imbalances between peer workers and non-peer workers, and the impact of high stakes employment, such as dealing with repeated overdose events and overdose deaths. Policy recommendations coming from survey participants focused on large-scale structural changes that addressed inequities of employment for people with lived expertise of drug use, and this included increased leadership roles for diverse people people who use drugs, pay equity and benefits, and more supportive working environments. So recognizing all that, I now want to hand it off to the members of the People with Lived Expertise of Drug Use Working Group to expand on these themes and share their perspectives.
Frank, do you want to begin?
Oh, sorry. Yeah, I can go. Yeah. Okay. The word peer is, to me, it's meaningless. It's a very derogatory word that's being used in harm reduction. When I first started at my agency, some 15 years ago, I started as a volunteer, and I was called a peer because volunteers are not being paid, they're not being recognized, and they're not considered to be staff, and so that's the way how I was treated. After they hired me a couple or 3 months afterwards, then we had the word change from peer to be called harm reduction workers. And we tried, well, what we have sort of have tried is to have that word harm reduction workers across the board in Canada. Some people agreed and some didn't agree. Now, if I was called a peer, I will not be doing the work I do. I would not have represented Canada at the United Nations when it comes to policy changes for 2 consecutive years. And not only that, then to present on race, harm reduction, and poverty. And also, then while I was there, I met with the Swedish government to talk about how could we open a safe injection site. Then I also met with the government of Mexico to talk about cannabis. So this is the point I'm making is that because I'm a harm reduction worker, I accept the invitation and I did that. But if I was a peer, I will not do it because I don't think I'm being considered or my voice is not being heard. I believe I have more to give in the Q&A as opposed to during my presentation. I'm open to answer any questions, but I just thought that my part would not be very long, but I'm open for all questions.
Thanks, Frank. We'll hear from everybody and then we'll open it up to question and answers. Sean, do you want to speak next?
Sure. Hello, everybody. I guess I just want to talk briefly on different types of research. I also want to keep most of the time left for a Q&A. I think that's where we can really get the best stuff. Anyway, I've been doing research for about 10 years or so, and I find it's really the vast differences. I've been part of some really great projects and some really bad projects. Some really good projects can be actually life-changing. I know for me, they certainly were, and to a certain part of my community as well. Like a good project I do, I guess I'm not going to name any names or anything like that or any specific projects, but I can just remember being included at every level, from regards to renting the building when we were going to conduct the research, to what type of research topics would be going at, what the questions were going to be. It was really, truly meaningful inclusion. The empowerment aspect of it, obviously I'm a person with lived experience, and I come from not very much, and it was the first time when I felt good about myself, that someone valued me and my knowledge and wanted to put that to use. And that just really felt really good after basically just doing harm to myself for so long. The third part, I guess, is the knowledge I got from it. Meeting different people, learning different things. Like I feel I've learned a new language, research language. I remember when I first started this, we had this one project where we were going to be working with 10 medical students. And I was like, oh my God, I can't believe I got to work with these people. This is going to be awful. But once I got down and we sat together and started communicating, by the end of the project, we were like hanging out with each other and, becoming really good friends. It's really great when, you can have a mutual understanding with each other. The flip side of that would be the bad. And I guess I'd be first and foremost a tokenism. So I've been a part of projects which I call the 10% rule. So the project would be like 90% done, 95% done, and then they'll come to you just to basically get it rubber stamped to have the peer inclusion part. And that leads me to my next part, which is, I always say this word wrong, condescension, which obviously makes you feel really bad. There's an ethos that we all use that could put, it's nothing for us without us. And, that should be from start to finish. So when you're just kind of added on at the end, just so someone can feel good about the research, that feels awful bad. And third, I think, and an awful under discussed part is the triggering aspect of it. It can be really hard on people who've experienced being constantly exposed to things that may trigger us, whether it's injection drug use or drug use or violence in the community and whatnot. And unfortunately, most positions that are available to people with experience are jobs that place us in the crux of that, where we're always front and center with things that can be very traumatic to us in that. So I guess just to close really quickly, bad research can really suck, but great research can be the impetus for great change. I think in Ottawa, a couple of projects that have been done have been, really the big reason why we've got, 4 supervised injection sites. And we've got also a very good safer supply program here. And I think a lot of that is because of the community research that was done and activism that was done that stemmed from the research. Anyway, I'd like to pass it to my friend, Michael, and probably give a lot more learned synopsis than I just did. So thank you.
Thanks, Sean. Thank you. And Frank. Yeah, I want to say thanks at the beginning to the Substance Use Project team at the Center for Public Health, at the Canadian Center for Public Health, for allowing me the opportunity to speak here today a little bit about peer work. And I also want to thank my fellow panelists for allowing me to share this, this panel with you. It's an honor. I've been a peer worker, and I'm going to use the term here. I've been a peer worker for the past 18 years. And I would say that it is a field that is an area that is constantly evolving, constantly changing. I mean, just like everything else in life. But it's also a very dynamic area. The findings from the survey, the themes from the survey, like tokenism and empowerment, as two different two different dimensions of the dynamics, to me resonates. Because for one, on one side, you've got people coming into work that offers them opportunities. And on the other side, you've got organizations that invite people into work that also presents opportunities, but I think a lot of challenges as well. So I'm seeing what we call peer work as a category of work. And my experience is that it is multidimensional. So we've got the service organizations saying, come on in and do some peer work. And often I find that the involvement of people who use drugs creates a category where organizations can access funding. And often that is the only thing really that they're interested in, because nothing is done to build out the effort or the delivery of services. But in a broader sense and in a deeper sense, it offers community organizations credibility within the community and ways to create inroads to reach people who are not really trusting of the service agencies. And like I say, it is also for organizations a source of cheap labor. But at the bottom of it, I think that it is recognized as access to needed expertise. And that also ties to the cheap labor as well, where people can come in and speak about how things are done, the experiences, and what strategies work among people who access the services, who use drugs. And that expertise, I think, is very valued. Well, if not valued, it makes a difference for organizations. And then we've got the employees with living experience. And I purposely say employees and not people. And for many, it is an opportunity to earn some money, to get some quick money. It is an opportunity to bring resource support to community comrades. It's like a lot of people see that, hey, I'm out here on the street, I'm delivering support to people around me, to my comrades every day, but organizations have resources. And if I go in either as a volunteer or as a paid worker, I can have access to these resources and I can guide these resources to my comrades. And it also provides people with an opportunity to grow self-esteem, to see yourself as valued. I think Sean mentioned that, like a way to feel like, hey, my life has value, and to grow that self-esteem. It also connects people with a purpose. Like you wake up in the day, you know you've got this to go to, and you don't have to wait till you get clean, but you can go and you're accepted within there. So it provides some purpose and some structure to your life. And you also connect with people who are supportive, with supportive colleagues, because you don't always find that when you're just actively using with no outside support. And it is an opportunity to grow knowledge and skills that could lead to further employment within an organization or even in different fields. For service users who are accepting services from employees with lived experience, people that they recognize, it is the opportunity for recognition of yourself and your personal life value. Like I remember like walking into a community that I'd used in many, many times and hearing, Mike, that is you. So, you know, like you get this recognition. It's not just a recognition of somebody doing a job, but it's a recognition of yourself. It's a recognition of your connection to this person. It's a recognition of the opportunity that this person is suggesting. So it is a recognition of yourself as more than just a stigmatized, criminalized person, and it can really raise your life value. It is also improve access for people accessing the services. It is improve access to navigation of services. So like, I know somebody who I can talk to if I feel like that person who doesn't understand me, who doesn't empathize with me. I know somebody who can do that. Somebody's coming into the community that I can connect with. So, and that person can show me how, on a level that is easy for me to get and acceptable, how to navigate services. And it is also enhanced opportunity to be real and share more. When delivering a service or delivering services to people on the street, people in disempowered situations, you're able to, when a person can recognize that, hey, you know where I'm coming from. You know what it is I'm going through. And if you can be able to reach from a place of realness, then people can see, you know, I can share more. I can tell you more about what's going on. And I can allow you to see what is really needed here. And that allows services to be developed to match the needs that are actually happening. And it also allows for the opportunity to have your needs and your situations spoken to and for. Like you see people who are working, who's been in the same place you are, who might still be in the same place you are. And you feel a validation of your life. You feel a validation of the choices you're making, the opportunities before you. And it also provides a connection to see modeling, to see how life can be lived differently. The other thing that
just wanted to give you the 1 minute thingy just so that you can wrap up.
Okay. So the other thing that I would mention that is extremely important in peer work is the principles of harm reduction. I think without the principles of harm reduction, there really would be no peer work. And that is, and one of the main principles would be meeting people where they're at, to be able to deliver from a place of humanity and dignity of all humans. Two things that impacts peer work is criminalization and stigmatization. And the other would be the work identified. I got thrown there by that 1 minute. What I want to say is that crucial to peer work, I believe that there needs to be a shift. There needs to be a shift from identifying the worker to identifying the work. Like, we don't say, like, even the title, I'll skip that till later when I get a chance to say. But we don't say, if you employ a person with a BA or MA, we don't say a person with academic or technical expertise working in harm reduction. We don't say that. But when we bring people who have that lived experience, we begin with a person with lived experience. And I believe because drug use is stigmatized and criminalized, and people who use drugs are criminalized and stigmatized, that image, that stigmatization is transferred to the role that is identified by the person. So we need to create a shift where we can simply say harm reduction service provider and leave the choice of whether that person wants to identify as having lived experience to that person. Because there are many people working in harm reduction who have lived experience who do not identify as peers. And I believe we need to bring that broad approach to how people enter employment so that we can also address the impact of stigmatization. I'll just say that moving forward that we need to look at policies that make sense to people, action for decriminalization, and perhaps most important moving forward for people working in this field with lived experience is we need to develop a strategy for dealing with grief support. The death of people who use drugs is gonna have, like, even when we bring that under management better, it is going to have a huge impact. Grief is going to have a huge impact. It already does. And we're going to have to look at how we deal with that and how to support people in wearing two hats, being in the organization and being in community. So yeah, thanks for letting me go over the time. But that's my...
Thank you, Michael. That was great. And hopefully in the question and answer, we can have more opportunities to speak. So bear with me while I see if this is a good time that we want to open it up for question and answer. So if anybody does have any questions, you can type it into the...
Oops.
Who's that?
Alexandra actually just was able to join, and she wanted to share her perspectives as well.
Excellent. Welcome, Alexandra.
Yeah, I'm so sorry for being late, everyone. I had trouble, so thank you for letting me in. I heard the end of what you were saying, Michael, and it resonated a lot for me. In Montreal, purple heroin just hit it, and in 1 day last week we had 7 overdoses at the injection site, and we lost 4 persons in a week. And we have to deal with grief, like what we do now, because it's so hard. Like you read the communication book and you find out somebody is dead, or on Facebook, that's horrible. So what we do, we hang a bird. So when this bird is hanging, we know that somebody passed, and we have a book where we put memories. And but we're in a mindset to learn that news, because it's really sad, but it happened more and more, and we're broken more and more. I remember Zoe Dodd once said, they tell us to go back to our community, but our community is dead, you know, it's really hard. I have recommendation for the inclusion of people who use drugs. There's something that I will always remember. It was the anniversary of one organization, and the theme they chose was the inclusion of peers. And we all had like a dot. The blue dot was for peers, and the red dot was for the outreach worker. And why? Why do we have to? What's the difference? And what if I consider myself? I had the outreach worker dot, but I'm a peer, and I will always be. I don't understand sometimes why we put so much effort to say who's who, because we can all just work together and we all have different expertise, but it's as valuable. So I think we should all try to continue working on that. One of the things that is really important, I think, is how to welcome people with lived experience when you hire them for a new job. Often what I see is people are let alone in their corner, or sometimes people are a bit condescending. And no, we have to find a way to really welcome and support people, and to make sure that we all have equal access to the services we work for. I know I was really late and I have no idea how many time there's left, so I'm gonna let the question and answer period start, I guess. Thank you for letting me talk.
Thanks, Alexandra. And hopefully you can say more in the question and answer. So now we will open it for question and answer. I don't see any questions in there, but I'll check the chat as well. It's hard to go through them. Does anyone have specific questions that could be put in the question section? Oh, I see one. Okay. How do we reconcile the findings from this study with the heterogeneous nature of peer work? For example, how can we apply these findings in different settings? I imagine because the way peer work is defined is so different in all different settings, and not just in harm reduction settings. There's also peer work in HIV work and all around healthcare, but also within harm reduction itself, there's many different definitions of what peer work is. Does anyone want to take a stab at this question from our group? If anyone in particular is interested. Michael?
Yeah, my sense, and I don't know if I'm reading the question right, but my sense is that the value of highlighting the identity or the background of the worker is not really to do with that worker or with the people that are being served. I feel that is something that has to do with the organization trying to qualify its ability or its image. Because if I walk into a community, whether it be HIV, whether it be drug use, and whatever the case might be, if I walk into a community, number one, I believe that the choice of outing myself should be my choice. It should not be the organization's choice. That should be my choice. And if I walk into an organization, it is the recognition of me within the community that is going to make the difference. Not what I'm called, not the title I carry, because I could walk into a community and nobody recognizes me and really don't even want to get close to me. So the point is that it is the recognition that I bring with my person into the work that would make the difference. So I feel like there need to be a general sense that outing somebody or identifying somebody as a peer isn't necessary, and neither is it helpful. So we need to shift away from that. The peer aspect of it is just about the organization. I think I come as a person fulfilling a role, and the expertise I bring is the expertise I bring, but it doesn't need to be highlighted over my head. We don't do it for others.
Thank you, Michael. I'll do the next question. Is there any efforts being made to represent harm reduction work in colleges, for example, nurses, doctors, and social work? And I'm not sure if this is an extension of that question. It says dismantling stigma may need to come from younger generations up. And I'll say that our work didn't specifically focus on nurses, doctors, and social work because most of people were working on the ground in relation to overdose reversal and providing supplies. But does anyone from the group want to speak to that question?
Well, okay. This is what I started in my opening remarks. I do a lot of presentations. As a matter of fact, next week I'm talking to the George Brown University, to second year students in social work about about harm reduction. And I believe, and something I've been saying for quite some time, to all the panelists and everybody and the participants, is that doctors and nurses must be trained in harm reduction. That is a piece that is missing when it comes to doctors and nurses, because they do not know how to treat how to treat clients, especially when they go into the emergency, into the emergency for treatment. You stay there all night and you're not being treated fairly. So this is something that we have to address, and I've been pushing this issue for quite some time.
Thanks, Frank.
I would just add to that that the alliance between harm reduction service practitioners and people who are using drugs is essential to any shift, to any change. And that alliance, I believe, within colleges and universities, if that is built, then it could lead to advocacy and pressure on universities to develop harm reduction policies. Policies that would then guide doctors, nurses, professors, so that you can bring everybody or bring as many people as possible on board and have services accessible that doesn't sit hidden because of stigma and lack of policies.
Thank you. So a next question, they're kind of jumping around. So I think this one connects to what was just said. Thanks, Frank. That's a provocative perspective. I agree, peer is problematic. As a person with lived experience or a person who uses drugs, a consumer, survivor, clean, or in recovery, generally someone who has experience psychiatricization in various forms. Peer, at least for me, includes an approach to mental health and substance use issues that critiques the clinical model and emphasizes respectful and dignified relationships with people. The term has often been co-opted, as Michael pointed out, without retaining the values that shape what is essentially a social justice effort. My question to the panel then is how to unify peer or harm reduction workers to do more than react to the poisoning crisis. I see plenty of stigma around mental health issues, acquired brain injuries, HIV, gender, and so on. So how do we call out those agencies that are taking resources out of mental health association services that are peer run? I hope I did justice to that.
Yeah, it was pretty long, but yeah. I'll try and retain what I remember.
Oh, sorry, Frank.
Go ahead.
Have you respond, and then Sean and see if Sean and Alexandra also have any.
Yeah.
Do you want to start, Frank?
Oh, sorry, sure. Okay, first of all, I do not believe that funding should go to any agency who is not looking at the overdose crisis. The overdose, okay, I've spoken to Health Canada just last week, and they have been doing very much when it comes to this overdose crisis. So therefore, funding should not be given to any agency I'm not against people in recovery, but I will not support recovery. That's me. I believe recovery is something a person should do on their own. There's no need for, and we have people who you can talk to for that, as opposed to giving money to groups like that. It's a very tough subject.
Thanks, Frank. Sean or Alexandra, do either of you have comments on that?
I don't right now, sorry, no.
No, I don't, thanks.
Okay, thanks. The next question is, let's see. How can government funded programs justify paying people who use drugs or peers less than others doing the same work? Sean or Alexander? Sean, yeah.
Yeah.
Go ahead, Alex.
Okay, well, it's always a question of degree, and I'm really pissed off with that, okay? Every year for 7 years, I speak to first grade student, future doctors at the University of Montreal. It's Dr. Marie-Ève Goyer, who is really cool, that invited me. And for all these years, for the hour and a half I talk, I get about $300, which is cool, you know, I'm paid as a professional. And this year's I do it and I receive a letter and they ask me, which degree do I have, first, second, or third grade? And I'm like, well, I don't have any, you know, and they said, okay, well, then it's $65 you're gonna have. And I'm like, what the fuck, you know? And they did errors for all those time. They're usually what they answer is that people went to school, paid a lot of money for their classes, so that's why they deserve a bigger salary. You know how many money I put in drug, man? That's my salary, you know, like it doesn't make any sense. It's our experience, competence, and knowledge should not be minimized next to a diploma. It really pissed me off. And subvention, it's the same thing. I mean, when an organization do a project, everything is counted, everything has to be proved after. So it's really hard, but we have a long way to go to have equal salary for peers and other type of workers.
Thanks, Alexandra. The next question, Sean, you might be interested in answering. I would like to know more about the employment conditions. How difficult is it to get a job? When that happens, what benefits you have or not? There are differences between, oh, where did it just go? There are differences between harm reduction organizations running by harm reduction workers and other organizations. I think that's a question. Are there differences between harm reduction organizations run by harm reduction workers and other organizations?
Yeah, it's all over the place. There's some agencies where you may be able to get health insurance or whatnot, but then your wage is going to really stink. Last agency I just left was like that. By the time I left, despite having 7 years of experience, I was making less than the people I was serving on ODSP. And it's really hard to get out and put out a 40-hour work week when, you know, you're making less than those that, you know, you really love, but, you know, you're just trying to serve. So yeah, the equity is just so far from being fair, and has a long way to go. It just seems to me a lot of times our opinions are valued until that point when it's time to remunerate us for our value and experience and that, you know. And I do really feel that the formal experience, the formal knowledge with the more informal knowledge that we have is the best way to, you know, accomplish things. I always feel that's always the best results. But yeah, to be treated on an equal basis, there's a lot of work to be done.
Thanks, Sean, and apologies to the audience if I'm not asking the questions in the order. They keep moving on my screen, so I'm trying my best. Here's the next question. Can you speak about hiring people with lived expertise versus people who don't, or those who don't want to disclose it, when both may end up with the same title of harm reduction worker, and anything to keep in mind? Anybody interested in responding to that?
A person with lived expertise do not need to be trained. A person who does not have that expertise has to be trained. That is one. Therefore, you know, if I have to train you, you know, I believe my wages and my benefit should be way up there. I should not be starting at level 1 or level 2. I should be starting at the maximum level. The person without the experience should be starting at the lowest level.
I would like to add something. There's different type of project for people who use drugs, and it's really important to know what our goal is and who do we want to hire. I'm gonna give an example, okay? Let's say there's 2 different type of job that is available, okay? One is to be give paraphernalia to people in the street. And for that, you have to be an active user and know the spots where even street workers and outreach workers don't know where to go or will not be allowed. You have to you know, like you use actively, so you know the spots. You just go to your places and you give material. And the other one is to do like reference and intervention and being in another organization for several hours. You're paid by the week. The first one you're paid after your shift. And but you need to have a bit of, you know, to be a bit more stable. You know, maybe you have your own apartment and you're able to wake up every day, you know, to show there every time. What we're gonna do often is that we're gonna hire the easiest person to deal with. So we want to hire the person to deliver the material, but it's harder to deal with somebody who don't have don't have a house, don't eat every day. You know, maybe yeah, for sure they won't show up, but when you create something like that, you have to think about that. That's part of the deal, you know, and you're gonna have to find solution together to try to go over that. What I saw often in these things, they take somebody who's not using anymore, and after that they won't deliver material to the people they're supposed to because they don't want to have cravings and things like that. And I saw so many times things done wrong like that. We really have to think about the type of project we want and what people we need, what expertise we need, and to find solution to work, you know.
I'd like to follow up a little bit on what, and I totally agree with Alexandra that that it really should be the role, and that role, the need identifies the role that you're developing, and that role would therefore say who is needed to do this work. So I feel like you start with the role and not looking at whether I want to employ somebody with academic expertise or somebody using expertise. But I also want to touch on a point, and while I respect where Frank is coming from about recognizing the expertise of people with lived experience, I believe that peer work is a marriage between expertise of using drugs and skill development to transfer that expertise into service delivery. So I believe that absolutely, totally, that training is necessary. Not training in the expertise.
There's background noise.
How you deliver those services. And I feel like often a lot of people who with lived experience are brought into agencies and are left to do the work based solely on the expertise. And I believe that the training and the support that is necessary to allow them to transfer this expertise into delivery, service delivery, is neglected. So I want to say that the expertise must be respected, but the training and the knowledge building also needs to be there in order to do the work.
Thanks, Michael. Sean, were you adding something? Oh, okay. I'm conscious of time. I think we have one more question. What are your next steps? What plans do you have for translation of knowledge from this study? And I'll just start with saying that everybody in the national working group are part of different service providers across Canada. So they're sharing this information with where they work. And we also have a report on this study that we've shared with people, and a website that we're putting up shortly, and trying to do talks like this to get information out. And the rest of the next steps actually come from the group themselves. So if any of you want to comment on that, it's open to discussion.
I kind of missed the question that you had put forward.
Just how we're going to share the knowledge from this study.
I think if I could just take a very vague stab at it, just keep advocating for me first and foremost, you know, going into meetings and, you know, pushing this agenda, because these things need to change. They're so important, and our voice is so vital in these conversations. And yeah, that's what I'm going to do. And I know my fellow members will do it. Yeah, keep pushing, keep advocating. Whoever will listen, like you guys, basically.
We have to continue advocating. We have to continue pushing this narrative. And every time we talk, we have to mention how, you know, this is what we are doing, this is the work we are doing, and where you can find all the resources. We have to make people knowledgeable of where resources can be found.
My part would be that through harm reduction, I believe that people who use drugs, people with lived experience, are developing a sense of themselves as not just, we having a sense of ourselves as just not stigmatized and marginalized people, but we're seeing ourselves as capable of doing things. And I believe that what we need to do is to harness that. Build user groups, build out user groups in the community that can share the empowerment that comes from being trained within organizations and being eager and passionate to create change, to build that unity and to be able to build that collaboration through user groups so that we don't wait for outside entities to decide what is possible for us or where we need to take. We know, as I say, who feels it knows it. We walk it every day, so we can articulate it and we can build it out toward change. So I say user groups for me is a way forward, one way at least.
Thanks, Michael. That is time, I think. My clock says 11. Thank you everyone for joining us. And I'm sorry we didn't get to answer all of your questions, but you can always reach out to us and we can answer more then.
Thank you so much, Jade. And thank you to all of our wonderful presenters for your really informative presentation and really valuable perspectives and insights. Thank you so much to everyone for engaging in the chat and the Q&A. And we apologize that we didn't have the chance to answer all of your excellent questions, but we really appreciate your interest in the topic. The webinar recording will be posted to CPHA's YouTube channel, and we'll send out the link to the recording as well as a survey link to all webinar registrants. And please stay tuned to the CPHA weekly update for information regarding future webinars in our substance use webinar series. And once again, thank you so much for everyone for joining us today, and we hope to see you all soon. Thanks very much.
Thank you very much.
Thanks. Thanks, Haley, Jade, and Tamar, too.
Yeah, thanks all of you.
Thank you, everyone, and thank you for the invitation.
Sorry for being late, but well, I did what I can.
It's nice seeing you, Alexandria.
Yeah,
how are you doing?
Yeah, it is. It is. Thank you. See you soon.
Yes.